right, so welcome to RTalk. I'm so excited today to be joined by 4 members of the respiratory therapy community who have willingly volunteered to participate in this panel discussion revolving around kind of the current state of respiratory therapy and really starting to pull back this onion and pull back the layers of RT as a profession, where we currently are, and hopefully maybe where we want to go. And I think it's very important that communication amongst practitioners is the key to tapping into our full potential, to getting everybody on the same page and not alienating ourselves and thinking, are we the only ones who think this way? And so first of all, I'd like to give my panel a big round of applause for being here with me today. I have Ronald Barrow with me. He is a staff respiratory therapist. I have Harold Oglesby with me, who is our administrative representative. I have Brandon Keeney with us today, who is our education representative, and then Ashley Seekworth, who is our student representative. So we have a wide range of, or a wide array of perspectives, which is, I think, extremely important, because there's no way any one person or one perspective is going to make a true impact in the field of respiratory therapy. So just for the viewers who are watching this, just so you know, I'm going to ask each person a question. They're going to have approximately 2 minutes to respond. Then everybody else is going to be given about a minute to respond to that. They can answer the question themselves, or they can respond to the initial representative who answered the question. So if we jump into this, I do want to take just a second to give everybody just a chance to kind of say maybe, your years of experience and kind of a little bit about your background, maybe just a quick, 30 to 45 seconds. And we'll start with, Ashley, go ahead and unmute your mic. I'm going to start with Harold and give you the first mic. And I do want to say this, Harold, for the sake of avoiding any conflict of interest with any facility, let's avoid naming any affiliation. So Harold, feel free to go ahead and tell us a little bit about yourself.
So I've been a respiratory therapist since 1989. I've worked in a managerial positions for probably about the last 20 years. I've seen a lot of growth and a lot of changes, and I'm excited about talking about some of the topics that you're going to bring up.
Very, very good. Ashley, who are you?
I'm medical background. I've been working in the hospital. I'm very excited to see where the growth is in career. I work with kids with cystic fibrosis as well.
All right, very, very cool, Ashley. Thank you. Brandon?
So, yes, Brandon Keeney. I've been in the field since 1992. I have spent a majority of my career in the neo-peds sector within the hospital. I've had a host of management roles, and I've been in education now for about a year.
Okay, very, very nice. Thank you for being here, Brandon. And Ronald, how about you?
I've been in the field since 1988. I've enjoyed a multitude of different adventures, from neonatal pediatric to burn ICU to adult ICU to transport to ECMO, and as an educator at 2 different facilities. Really excited about this opportunity, and I look forward to the questions you have.
It's very cool. What we see here is that nobody really truly only has one perspective, because we see that the panel here is going to be able to come to this from multiple different perspectives. So Ashley, if you will you unmute yourself? Keep your camera off, because we had a little bit of problems. Well, let's just test the audio here real quick. Tell us again what your role is.
So I've been a medical assistant. I've been working in a hospital here in my local community. I'm a first-year respiratory student, and I would like to get into working with kids with cystic fibrosis.
Very good. Okay, thank you, Ashley. That was much better. Heard it much better and much clearer. So I'm going to go ahead and jump into the questions now. Ashley, the first question is for you. So you can unmute yourself. So here's the first question I have for you, Ashley, is from your student perspective, is there a disconnect from what you learn in the classroom to what you actually see at the bedside, in terms of not only the therapies and the modalities that are happening, but also in the way they are administered versus what your educators are teaching you in the classroom? And if so, will you please elaborate on that disconnect?
Yes, so we notice a lot that we're being taught old school ways. We're learning about older equipment, just the education behind everything, and we're not applying that to like our clinicals. Everything is, we're basing everything on a real patient when we're out in the field. But while we're in school, we're just being taught like the normals, like the basics. Like we're not being taught like how to correctly manage a critical patient, which I don't agree with. I feel like I would like to know more when I'm going to deal with a patient. I understand, the patient, that we're treating in the sim lab, is going to have normal, but like somewhat critical values. But in the real world, that patient needs to be treated better. And we're not really being taught that. So that's like one of the things that I've noticed that I just don't agree with right now.
Okay, thank you, Ashley, for that response. Brandon, we're going to shift to you. You can either respond or kind of touch on the same question, being, is there a disconnect between classroom and bedside application?
I would say that I would have to agree in some elements of what Ashley said. There is the evidence-based medicine way that I think we endeavor in education to try to bring to the educational piece. But then I start seeing some of the things that go into conflict with what they see at the bedside. So we know that, there's all sorts of uses of albuterol that may not be indicated. We teach that. The NBRC focuses on that. And then you come out and you see albuterol just being ordered for everything. So I think a lot of people will probably share that sentiment. As far as her specific instance of programming, I try to tie what I have experienced from the hospital, being that that's a majority of where I've spent my time, especially in the ICU setting, in the trauma setting, having done ECMO as well. So I try to bring all that back to the students. So I try to stay away from idolization, and I try to make the students very aware that this is all going to have a different flavor when you get out in your clinicals, and every place is going to be different. So every hospital culture is going to treat these elements a little bit different based on where they are.
Yeah, absolutely. Thank you, Brandon, for that. Ronald, you're next.
I tend to agree with Ashley. From what I see of the new graduates that I precept, they tend to lack some of the knowledge I would hope that they would have. I think the bigger portion, though, is the critical thinking skills, dealing with ventilator management or patient management, and knowing the whole patient. I was quite amazed when I presented somebody with lab values and they did not understand the lab values. So I think there's the whole picture presentation that can be very lacking, and it puts them at a negative, let alone some of the other critical thinking skills about assessing the patient to meet their needs and sometimes thinking outside that box. I have so many people who say, well, we need to use SIV mode, but they can't tell me why. Or we need to do this, but they can't tell me why. And that can be frustrating because you got to start teaching again post education.
Yeah. Well, we all know, well, if you know me, then you know that my why are always greater than the hows. And so I can share that sentiment with you, Ronald. Harold, I'll let you wrap up this conversation.
Right. And since I'm last, I'm gonna say ditto, because I've seen the same things that everybody's talked about. Often we have students that report into our ICUs, and they're not academically ready to work in the ICU. When they're asked some questions like Ronald just said about detailed information about the patient, that they can't respond. And there's sometimes in clinicals, in class, learning from folks who have been removed from the bedside, who are trying to instruct them. So that's sometimes why they end up with the old school thought processes when new school modalities are sitting in front of them. So it's re-educating after they've been supposedly educated.
Okay, fair enough. All right. Next question is going to go to Brandon. This is my educator question. And I'll just say it here. There seems to be a gap between theory-based education. It's actually right on cue. There seems to be a gap between theory-based education and real-world application. And my question is what part of the theory that we teach, that you teach, what part of it is not applicable? And this question is kind of based off of this theory of that, I hear from students who say, like, I asked the therapist this question and they said, oh, I haven't thought about that since I was in school. Well, what part of what we learn in school isn't applicable at the bedside?
Well, once again, I think that is best answered by the institution and the culture and what they're asking of the RTs historically of that institution. A lot of our hospitals don't ask a lot of the RTs, so the RTs are not challenged. They're not challenged both by the system that they have grown up in, and they've not, certainly once they've gotten the hospitals, when there's not a lot of demand for what they learned, it goes away real quickly. Some people are okay with that. Other people can't stand it, and they go find where they're going to be challenged. So what's left is, and I don't know if you're familiar with Oklahoma. Oklahoma has not challenged their RT population very much. There's not been any really development of the RT professional model. In the state that I came from, Ohio, so I was very shocked when I came here to see that there was not even one bachelor's degree program in this state. So I was a little taken aback by that. But I think really when you start talking, we're teaching 88 gradients and what that means. And I try to be very conceptual about what that could actually mean as far as pressure gradients. But where does that actually come into question when you work at a community hospital that hardly ever has an ICU patient? So that goes right out the window. So only when you get up into the city, Oklahoma City, where you start really seeing the worst of the worst, would you actually start putting that to use. So I think a lot of it's where you are and what you're actually utilizing. So I think, it's a very heavily weighted question in that hospital culture. Once again, we can give the basics, but if the basics, there's no ECMO program for you to go to, or no transport team where you can actually start using your higher level skills, which didn't exist in this state, at least I saw, you quickly lose them.
Yeah. Ronald, what are your thoughts on this?
I have a couple thoughts on it. First off, I get frustrated with old therapists who fail to challenge their own mind on a constant basis. I can still tell you the alveolar air equation today, 35 years later. I can cite you the VDVT equation. I challenge my people that I work with all the time for those kinds of things and apply them. And when speaking with a physician, it's important to apply your knowledge to, one, gain their trust, but also gain the collegiality that you need with them to become a better team. So I think there's a challenge with people taking it upon themselves, no matter what environment they work in, to bring the best out of themselves. But I do agree that, we have a scenario where, a lot of therapists or a lot of areas are not challenged. I've covered the U.S. Over my entire career, a lot of the areas. And when I'm down south and we intubate, put in A-lines and manage the ventilators versus being up north and I'm basically told where to turn a knob, it can be a little mind numbing and frustrating. I think we should be able to practice to the level of our license. And it's disturbing that everywhere is not the same.
Yeah. Harold, what are your thoughts?
Well, I had the good fortune of being down in the South, so we challenge our therapists to use those things that they learned in school and to expand upon it. And they really don't have much of an option because some of my therapists will probably they walk away from me when I come because they think I have another test for them. So we create an annual competency test that just refreshes all those things that they learned in school and some of those things they should know at the bedside. So it's a challenge for them. You know, we've had some staff turnover. So you have folks coming from other areas, but we have to make sure that everybody's performing on the highest level that they can. And just like Ronald said, our practice at our facility is we practice at the highest extent of our licensure, to include some of the things that we talked about earlier: ECMO, A-lines, intubations, and being a resource for the physicians. They will come to my therapist before they will go to the nurse.
Very nice, very nice. Ashley, are you able to unmute?
Yes.
Okay, what are your thoughts on that, Ashley, from what you're seeing from the student perspective?
I mean, so what I like, especially with what I want to do, where we are in New York, a lot of our therapists will not intubate. There's a lot of older anesthesiologists who do not want to take on an RT student to learn the intubations. So like for me, being a student, I want to come out and I want to be able to, you know, manage an airway properly. I mean, this is what I'm being taught. So I want to grow in the field. Like New York, we only have a few bachelor's programs that are in person on campus. Everything else is online. And it's just, for New York, for respiratory therapists, it's not ideal for career development if you want to be in a critical situation. So I, you know, like with what Harold and Ronald were saying, being down south, you know, you get to do a little more. I think, you know, as an RT who's hungry and eager, that would be, you know, I'd relocate. I would like to, you know, participate more with intubations, managing ECMO. You know, we're the new generation. We're hungry and eager to do this stuff. So it's just, you have to find placement where you want to go and make sure you're, you know, you're completing your competencies. You know, you want to stay up to date. You want to stand out from other therapists, especially now in school. You want to stand out.
Very cool. Thank you, Ashley. I like that, eager and hungry. I like that. I like those words. Okay, we're going to go on to Ronald now. Keep this going. This is my question for my staff therapist. And I think it's also fair to say that what we're seeing here is that there's a regional difference in all of this. And I also wanted to, I didn't throw this out early on, so I want to put it out here now. Any of these questions are not meant to generalize for everybody. They are just questions that routinely come up to me and emails I get, and just issues that we need to talk about. Okay. So Ronald, many staff RTs complain about the lack of respect that they receive. But at the same time, they continue to stack therapy, perform concurrent therapy. They're reluctant to respond to nursing calls, and they spend more time in a break room than they do on the floors and with their patients. So my question is why are so many RTs reluctant to provide one-on-one quality care? And is this directly tied to the lack of respect that they receive?
Well, I can't explain why they want to refuse to provide one-on-one care. I can tell you that this is one of my pet peeves. The collegiality and respect that you get from a physician is earned. It's not entitled. And I think that's the way a lot of opinions that I hear from my colleagues think that they're entitled because they have credentials behind their name. I've always said, if you really want to gain some respect, you go to a physician and ask for Q2 treatments because the patient needs them. And when you go back to that same physician a week from now and ask for treatments to be discontinued because they're no longer required, that physician knows you're there for the patient, not for just to get out of work. So it is a frustration that I have sensed, and again, not regional, everywhere. And even to the point of, you know, when you're in ICU, stay in the ICU. You being the ears to that ICU, you will know what's going on. You can't tell what's going on from the break room. And it is a pet peeve that I deal with consistently, no matter where I'm at. I don't know how to correct it. And I don't need to be challenged to correct it anymore. But I do encourage people to become professionals, you know, so.
Yeah, thank you for that, Ronald. Harold, you're up next.
Sure. So you're always going to find there's going to be some folks that are more eager to do the work than others. I would say that the majority of my folks will actually enjoy being at the bedside, enjoy being a resource for the patient, the physicians, and the rest of the medical team. and they're dedicated to be that resource. And I think part of that is just because they're challenged on a regular basis, and they do get that level of respect. So when a physician asks, should I transfer this patient and just code it to the unit, or could you keep them on the floors? Or if you have the rapid response team report, and you call the physician, and they'll say, well, I talked to the RT. And if the RT says, I think we can keep on the floor, put him on some BiPAP and see how he does, get a blood gas in an hour. 95% of the time in our facility, the physician say, okay, keep him on the floor. If that same therapist says, we need to go to the unit, 97% of the time, he's going to say, go to the unit quick, fast, and hurry. Go ahead and intubate the patient, put him on the vent, call me with the gases, 30 minutes. Don't ask for ventilator settings, because we have protocols. Allows the respiratory therapist to make those decisions, and having that autonomy and having that level of expectation is key. But in order to keep it, you have to practice at a high level and use those things we talked about earlier to make sure that you're doing the right things. And once you do that, you have that respect. And I think it adds to the people getting away from the break room and actually doing the work.
Very cool. Ashley, you're up next. You want to unmute yourself?
Yeah. So I definitely agree with what Harold weighed in. I know I see I work in a med surge hospital. So what I see is that a lot of our CNAs, kind of like RTs, they stood out. They're busy, they're so knowledgeable, they're key players in just managing the patient's care. But I think with certain hospitals, they're not respected as much as they should be. They should be very valuable, very valuable key to the patient's success and getting out of the hospital. But I think it's just, some hospital dynamics, they just don't respect the RT. Not a nurse, they're not this, they're not a doctor, they're not a PA.
Okay, so we momentarily lost Ashley. Maybe she'll jump back in here. But Brandon, I'll go ahead and give us just a second here.
Want me to go ahead?
Yeah, go ahead, Brandon.
So to add on what the rest of the group is saying, I think once again, to find those hospitals where the expectation happened very early on and it's maintained itself, where the RTs act to practice at their scope, top of their scope. Those are what I'm hearing that the students are trying to find, but it's not very well communicated. There's not this place like saying, well, what is the scope? Where's the book that says what RTs are saying at each one of these facilities, and where you would see RTs migrating to those? It's like these are well-kept secrets. I've been in academic medical centers my entire career, and there was always this hierarchy who got to do stuff, because you as an RT, you were very pushed back to get to do A lines, or especially in pediatrics and neo, to get to do A lines and innovation, because you always had the lineup of the residents and then the NMPs. And once that culture sets in, it's hard to loosen that up. I mean, and if you don't have big buy-in by the medical staff, very hard buy-in, and a champion for that, you're not letting that kind of culture, you're not overcoming that. So people get very defeated and get very complacent. And then the better people will find their way into the transport teams, onto the ECMO teams, and to the better hospitals where they get to do this stuff. And this regional effect of hearing what's going on at Harold's hospital, I would love to be able to point my graduates there. But a lot of our graduates are bound to wherever they're living, so they're kind of stuck with the cultures that they're surrounded with, because most of them are associate degree programs, and they are really in those areas for a reason. They can't just go up and move, if you will. So they're kind of tied, but it's good to hear.
Yeah, I think we lost Ashley. If she jumps back in, she jumps back in. If not, we're just going to keep moving. So my second to last question here, and then I have one final question for everybody, is for Harold, our administrative representative. I hear from a lot of therapists, and I asked them on this topic of concurrent therapy and treatment stacking. I asked them, I said, why are we still stacking therapy in 2023? And they take their sheet out and they go, look, Joe, look, I got 80 modalities today. How else am I supposed to get it done? I talked to directors and managers, and they all seem to send the same message. Also, they say, well, nobody does that in our facility. We have a policy that says you will not stack concurrent therapy, even though the therapists are going out with these unreasonable workloads. And so my question is from an administrator's perspective, what's the perspective of these workloads that are being assigned in conjunction with this idea that quality care is desired, but the workloads say something else? What do you think?
Yeah, so I've seen my staff's workload on multiple occasions. I know what my staffing capabilities are, and it doesn't match what the workload is. So I always tell my folks that to triage their patients the best they can, to focus on those patients that really need the treatments. We have systems that are built in to do just that. Some of it's done through the EMR for those patients that really need to have the treatments. Most of it's done through communication, particularly during the report. So we have structured reports, and we don't push anybody to do multiple treatments. We don't go at the end of the day and say, you didn't do 70 procedures. We look for quality over quantity to take care of our patients the best way we can. There are often short shifts, and folks that would be truly overworked, and they probably wouldn't be there the next day if we worked them to fulfill that list that they leave with. It just wouldn't happen. They would be burned out in a heartbeat. Although I have some that will try to do everything they can, and those are the ones that will get frustrated, and by the end of the day, pulling their hair out. Like the majority of therapists are really good at one thing, and that's assessing patients. And those that can use that assessment skill to know who they need to treat will do the best jobs and get the work that needs to be done. But I don't harp on a particular volume that you have to get done. You have to get everything done. As long as you're taking care of patients the best way you can.
So I just want to clarify real quick. I know I'm breaking script right here, but you, Harold, would prefer to see a large number of therapists not available charted rather than seeing those unreasonable workloads completed. Is that what I'm hearing?
Yep, I can pull up a list right now and show you.
Okay. All right. Very, very cool. Brandon, you're up next with the response to this.
So I think what we're really talking about here is the volume-based versus value-based.
Yep.
And this is a big thing that has forced itself, and it's reared its ugly head really in the era of COVID. Having come from the hospital in this, I was trying to do what Harold was doing too, but essentially, if you don't have the staff to even do the bare minimum to try to make sure that occurs, it can be very difficult. So really, I think the best prescription of what I've heard with one of our affiliate hospitals was they couldn't get to these workloads. They finally realized, why are we trying to do a Q4 therapy on a patient that's not even here for respiratory, that's on a BID at home, but they get in the hospital and some kind of provider orders Q4. So they moved everyone to BID except for those that are actually there for acute respiratory reasons. And they were able to really start accommodating their patient loads better. They were able to see their patients more meaningfully. They were not nearly as overwhelmed with the therapy. And what I think that this would lead to is a great study of pre and post interventionals that would say our readmission didn't get hurt through it, and we did not increase hospital length of stay, and it was really a better utilization of our ability to project this work in a more meaningful way. So yeah, I know with these therapists that always think they have to get everything done, but this hospital was actually forced to relook at their utilization. And from what I understand, things are a lot more manageable because they are actually doing more meaning and more value to the work they're doing. And this is a big hospital. So I would love for my director there to give me some data, because I would love to do the paper on it, but I can't do it without that.
Well, I think this is exactly what we need to do. We need to get these type of facilities, Harold's facility and the facility you're speaking of. We've got to get all these facilities talking to each other to help share the secret on how this was done. Ronald, what are your thoughts on this?
Well, of course, I grew up in respiratory, and when we were a revenue center, we never had these issues. I think once we became a cost center, these issues have been swelling over the past 25, almost 30 years. And with the enablization of bean counters and productivity, that's one number I just cannot tolerate, or one term I can't tolerate, productivity. We're not a factory. They want you to put out more and more service with less and less staff, and it's almost impossible. First director I ever worked for, he said, you tell me when you can't get to a treatment, because that gives me the power to go to administration and explain why we need more staff. But I do agree, what are the outcomes? What are if we're not affecting outcomes by triaging therapies, there's probably nothing wrong with that. We do give a lot of therapies to patients who do them at home all the time, who aren't in for a respiratory reason. But at the same time, Brandon, I think what's interesting, I've been at facilities where the consumption of respiratory therapies have been by nursing. Nursing's doing our work now because we are too shortchanged. And so we're giving away, and I hate to use this term too, but territory and our specialty. Um, and it's putting us still based on how much volume can we produce with even lesser and lesser staff. And we have to look at how proving our value somehow to the hospital to show that having the people to do the job effectively actually will help their numbers and their DRGs and everything else. Another, just a quick ad hominem. I get tired of hearing about how much we charge patients, and I hear this from our staff. We don't charge patients anything. Yes, private patients, they get a bill, but Medicare patients are DRG based. We can do 5,000 treatments or 5, and they still get the same bill. We don't get reimbursed any more money, but that still lingers from our old leadership, like we're getting paid. And that's another frustrating thing that occurs.
Yeah, I have a tendency to agree with you there, Ronald. So, like I said, we lost Ashley, so we're just going to keep moving on. Here's my last question that I have for the three of you. I, kind of asked some questions here that kind of shine a light on some of the areas of improvement, or kind of some negative areas maybe. So I want to end it on a positive note here, and I want to give each of you a chance to share one solution-based action point that you think, you think about respiratory therapy 20 years from now, 2043, what is one actionable item that you think would be valuable to moving respiratory therapy to fulfilling our full scope, not just in one region or another region, but across the country? And we'll start with Brandon.
So one of the things that I really, in the last part of my hospital leadership, were to tie back the things that we were doing more through the lens of safety. So if we have a large hospital where we're doing a lot of non-invasive things, so we want to always make sure that we're there with the nurse as a partner, preventing harm in the form of skin injury with non-invasive elements. If we're talking in neonatal, those kids tend to lose their tubes more often than other populations do, because we don't sedate them. We certainly don't restrain them as much for neurodevelopmental reasons. So we need to make sure that we're being very mindful where the tube is, so to prevent unplanned extubations. Also to prevent ventilator-associated VAE. So all these types of things of harm where the RT can align their purpose back to the preventing elements of harm. That's what I was trying to do, to give us more of a sense of purpose in general for safety and better outcomes. So I would like to see more of that and that discussion, rather than we've just got to do this stuff because it's on our list to get done.
Very nice. Ronald, you're up next.
2020 initiative that was thrown away. Bachelor's degree requirement minimum. Enhance our entire professional stature, be it medical knowledge, be it skills, be it as a part of the healthcare team. I think as long as we maintain a status of associate degree or less, we are going to be continued to be treated as a lesser individual throughout the entire system. I'm looking countrywide. There should be no reason why someone in Oklahoma can't practice the same way I did in Florida. But professionalism and credentialing does make a difference. But at the same time, too, advance yourself. Get your ACCS, get your NPS, get ACLS and PAL certified and NRP certified. Do everything you can to promote yourself as an individual is so important also.
Absolutely. Harold?
Yeah, you can see my wall. I got degrees and certificates all over the place. So, and I encourage all my folks to do the same. And, years from now, I would like to see us advance in our profession to being those advanced practitioners that are at the bedside. So our pulmonologists come in, our therapists already doing advanced things. They're doing the ECMO, they're doing the A-line replacements. They're going around with the sonocyte and ultrasounds, doing ultrasounds on patients. They can do the same thing our PAs do. And whenever they have those opportunities to do it, they do it well. So we have an anesthesia assistant PA program in town. Every therapist that's gone to that program has shined. They've done well. I sit on the Canadian Society editorial board for their journal. When I go up to Canada, I'm sitting with those folks. Half of them practice anesthesia, not respiratory therapy, but they only go back to school for a short period of time to achieve that. We should be at the same level down here.
Very good. I think for me, what I'm hearing is two words that you can find in the ethics chapter of Egan's, which I usually have this stuff memorized, but I don't today, is the word beneficence and non-maleficence. And I think if we as a profession could find a way to be more involved in those two words and finding what is needed to benefit our patients and eliminate what is only going to provide harm, then I think everything that you three have stated is right on track. And so I just want to say that I thank you. That wraps up the time that I've asked you for today. We're right at about, from the time we got started, about 38 minutes. So I'm going to go ahead and wrap this up. I thank you so much for your time today. Ronald, Harold, Brandon, Ashley, thank you for the time she was on here. And if you're watching this and you want more information, feel free to reach out to me. There'll be information in the video description below. And if you want to reach out to any of these individuals, I'm sure that I could probably get you in touch with them. So just feel free to reach out and communicate more. And remember, at the end of the day, average is easy. Don't be it.